Welcome back to Medical Mondays. We're talking about pain, and Dr. Yelameli is here from the Nashville Pain Center taking a lot of calls today. And Marcia, I think we have you back on the line. Hi, what's your question tonight?
Hi, my question is, before someone is referred for a surgical procedure, are other holistic modalities such as acupuncture, massage therapy, reflexology, hypnotherapy, yoga, Reiki, biofeedback, and even something such as a vibrational session with the Tibetan singing bowls? I heard the doctor mention something about a surgical procedure that involved a vibrational process. So how would he respond to that question?
Yes, that's a good question. So there are multiple other modalities that are available out there, which are which we put them under the umbrella of alternative medicine. So as an allopathic physician or a modern medicine physician myself, I do not practice those other modalities that you just mentioned, but there are times when we do refer patients for acupuncture. We do say, okay, let's go try that, try other modalities if the patient is interested, certainly. But if you are looking for a longer term relief, and if you have severe pathology in your back, let us say you have a degenerative disc at 3 levels and you have severe arthritis in the back, and if you're trying acupuncture for that, it's unlikely that it will give you a long-term relief. So you will have to continue to do the acupuncture on a regular basis for months and months and months, like on a weekly basis, which probably may not be practicable in the case of pathology. So it depends on the patient. It depends on what kind of pathology you have. It depends on what kind of pain you have. So if there is not much of an objective evidence of pain in your body, then I don't mind, if you try other modalities like massage or acupuncture or other things. But if you have a severe, serious problem and it looks like it requires surgery, then I will not be asking you to do those things. Most probably I will say, let us try some injections and then send you to the surgeon for a surgery. We do use biofeedback as one of the modalities in modern medicine. It does work. It has been proven successful. We do use biofeedback.
Explain biofeedback.
So it's about basically sitting in front of a computer. Sometimes it is technological issues are there. Sometimes the patient has to sit in front of a computer and control the feelings, control the emotions in the mind, so that certain parameters like blood pressure, heart rate are brought down, so or concentrate on the pain and bring it down. So biofeedback is another thing that we use, but these are certain things that we use for conditions that really do not present themselves with real structural pathology in the body, like let's say fibromyalgia, which is a condition which causes pain from head to toe, severe tiredness, and really you cannot come up with one single investigation in the paraphernalia that we have that will show that the patient has fibromyalgia. So it's a diagnosis of exclusion, wherein we pass the patient through the entire lab work and investigations and imaging and everything, and then finally, if we cannot find anything, we say it's probably fibromyalgia. There are certain definite signs and symptoms of fibromyalgia that have been developed over the past few years, and now more and more patients are diagnosed with fibromyalgia. So these are conditions where narcotics are not advised and procedures are not advised. There is really no procedure you can do on these patients, and there is no surgery that can be done. And there are some non-narcotic medications that are helpful that can be used, and of course other alternative medicines can be used in these cases.
All right. Okay. I hope that answered your question for you.
Thank you.
All right. Thank you. And Sylvia. Hi, Sylvia. What's your question for the doctor tonight?
Yes. I woke up in severe pain. I couldn't even move. This was 3 years ago. I went to 2 different ERs. I couldn't figure it out. They finally said it was polymyalgia, high inflammation. They put me on prednisone. I've been on that for 3 years.
Where is the pain?
Now they said it's going to turn into rheumatoid and fibromyalgia. Is that possible?
So where exactly was the pain when you said you woke up with pain 3 years ago? Where exactly was the pain?
My right leg and right shoulder was frozen.
Okay. And none of the imaging studies showed any pathology in your shoulder or in the lower back or in the leg?
No, but after, as it kept going on, it started to spread to my left leg and my right shoulder and my hips.
Okay. Have you been to a pain specialist?
No.
Maybe you should try to see a pain specialist. Sometimes there are certain conditions that can present like this where an imaging study may not show anything. An MRI may not catch an early stage arthritis. An MRI does not show a neuropathy, a nerve damage. An MRI may not show. You might have had a very a mild injury. Let's say you sprained an ankle or you sprained your hip or a knee or a shoulder, which may be, you may not have even noticed it at the time when it happened. And we have certain conditions in pain that are very specific for pain itself. It's a pain disease. It's not some other disease causing pain. It is a disease by itself. Let's say reflex sympathetic dystrophy, which is a disease in which nerves get damaged even after a trivial trauma like an ankle sprain, and can start spreading to other areas of the body and cause extreme severe pain. This is one of the most difficult pain conditions to treat. It's called, now it is called complex regional pain syndrome. Earlier it was called reflex sympathetic dystrophy. So we may have to send you to a neurologist and get some nerve conduction studies to see if you have a nerve damage anywhere, because neuropathies can present like this. Have you had any of those tests?
No, but I am a chainsaw carver, so I do a lot of lifting and vibration of tools and all that.
So that can be a cause of this too. So patients who use vibratory instruments like you can develop neuropathy. You can have repetitive injuries also to the joints and ligaments and muscles. So one needs to examine you thoroughly with and send you to certain get some investigations done and see where the pain is coming from. The pain will be either coming from your nerves or muscles or connective tissues or joints or from the spine. So we rule out all these things first, and then only we can say, all right, we can't find anything. But it's typically rare for us to say that we can't find where the pain is coming from.
Great. I'm going to give you a call.
Sure. Thank you.
There you go. Thank you. Thank you. And feel well, Sylvia. Thanks for the call. And Ruth has been waiting patiently. Hi, Ruth. What's your question?
Yes. I have had 3 back surgeries, and I have been told that I have peripheral neuropathy and arthritis, and the pain is in my right leg. It's so severe. I could tolerate the pain in the left leg, but the right leg is just horrible. And I have been referred to the pain center here, and I'm taking 5 Neurontin pills a day and 4 or 5 hydrocodone to control the pain. And I want to see what the doctor thinks, if that is too much pain medication or what he would advise me to do.
So you have pain in the leg, you're saying. Is it coming from do you think the pain is shooting down from the back, or is it just in the leg?
Well, now, I have been told different things, that it is coming from my back. I had spinal stenosis. And this pain is just, it is absolutely so severe that I can hardly tolerate it in my right leg until I take my pain pill. And of course, taking the 4 or 5 pain pills, I have to suffer quite a bit before I can take another, and I will not take any more than what I am prescribed.
That's good.
for.
That's good.
I'm
yes.
a 78-year-old woman.
Yeah. So when you say you have pain in the legs, the pain can be coming from the lower back, as you said, spinal stenosis you have, and you can have neuropathy in the legs from, let's say, diabetes or any other cause. Neuropathy can happen even without any cause.
I don't have diabetes.
Okay. So,
that.
Right. So, but you have had some studies that showed that you have neuropathy, right?
Yes, I've had the neuropathy biopsies.
Correct. And you may have arthritis of the joints too. You can have a knee joint arthritis or a hip joint arthritis. That can also contribute to your pain. So sometimes it's not all, you can't put all the, everything, just say that it's all coming from the back, or it's all coming from the neuropathy, or it's all coming from the joint. It can be a combination of several things. So every time you have pain, we have to examine you. Every time you come with a pain. Let us say I do an epidural into your back. It will only take care of the pain that's coming from a pinched nerve that is shooting down your leg, but you will be still left with the knee pain that's coming from the arthritis. It won't help you with that. So I may have to do a knee arthritis injection, a steroid injection to the knee, or there are certain other injections that are available that are non-steroidal, which can do into the knee, or we can do an MRI of the knee and send you to the orthopedic surgeon to see if you are a candidate for surgery. If you have neuropathy, we can treat you with certain drugs that help with neuropathy. Sometimes I have seen.
Well, do you think for the time being that 4 or 5 hydrocodones is too much to be taken in one day?
I don't think so. If you have so many different conditions, if you have such severe stenosis and arthritis and neuropathy, then I don't think you're on a very high dose of opioids. But any dose of opioid, every milligram of opioid is prescribed with a lot of care and with a lot of concern. We don't take even 1 milligram of hydrocodone, lightly. We take every milligram of the narcotic we prescribe very seriously. So it is always better to decrease the doses. But I don't think you're on a very high dose of narcotics, given the fact that you have so many different conditions.
Well, I thank you for telling me that, because I have been rather concerned, afraid that I was getting too much.
Right. It sounds to me like Ruth, you don't even, she doesn't really want to be on the medication.
Right.
I mean, what could be done so she would have to take the pills?
I don't think there was any way that I could have the relief from the pain.
Right.
Yeah.
I mean, certainly we have, I have seen patients like you who have come and who have severe pain like that. You know what has happened is sometimes when you have severe nerve injury in the back, let us say you have a severe pinched nerve in the back, or you have a severe neuropathy in the leg, it can develop, I have seen this happen, it can develop into the next level of neuropathy, which I was explaining earlier, which is called reflex sympathetic dystrophy. So what I have done is I have done sometimes sympathetic nerve block, which is a different kind of injection that we do in the back. Doesn't go into the spine, it goes in front of the spine actually. We go from the back and we reach across.
Now, I don't want to take your time, but I want to mention one more thing of hardware in my back.
You have had surgery, right?
Yes, I had
right,
it down
See,
at Vanderbilt.
Yes, so there are a lot of things going on here. So I don't think you're on a lot of medications if it's helping you well, but if it's not helping you, then probably it's probably inconsequential whether it is high dose or low dose.
Okay, I have your number.
Okay.
And I'm going to talk to my husband, and hopefully I can call and possibly get an appointment with you just for another opinion.
Sure.
But that's a smart move to make, huh?
Yes.
Ruth, thank you so much for your call.
Thank
and
you.
I feel terrible for you, so I hope you get to feeling better somehow.
Okay, thanks so much.
Okay, thank you.
Bye-bye.
Bye.
See that, and I just, I hate to hear that when she obviously doesn't want to be on the medication,
Right,
but
no.
she's in so much pain.
Correct. Yes.
Okay, so, and actually that brought me to another question, which I'm sure I'm guessing you see a lot of patients with arthritis pain.
Yes. Of course.
Which can be severe.
It can be.
And so what are some routes you take for people who have severe arthritis?
Now, depends on where it is. So there are people who come to us with shoulder arthritis. There are patients who have knee arthritis. I have seen several patients who have arthritis of the ankle joints, which is not as common as the knees, and they have hip arthritis. So typically, if it is a milder version of arthritis, milder severity, then we just manage them with milder non-steroidal anti-inflammatory drugs, ask them to avoid bearing weight. So there are some patients who are just working out in the gym, doing heavy weights, and then complaining about. So we tell them, look, you have to just do stretches and not do heavy weights in the gym. Or if they are obese, we ask them, we find ways to decrease their weight. Weight reduction is itself a big treatment it's a very effective treatment for arthritis. Oh, wow. So we work with them. We see what may be causing the arthritis, what may be keeping the pain going. So it's most of the time it is obesity, or it is the lifestyle. Some patients are construction workers, or they're lifting heavy. There are managers in big warehouses, big stores, where they walk the whole day on concrete floors from one end to the other. And of course, they will have severe pain from even mild arthritis. Right. So a patient with a severe arthritis can be just sitting at home and not having much pain, but a person with a mild arthritis can be doing a very hard, strenuous labor and suffering a lot of pain. So it depends on what we see among these patients, and then we give them the right advice. So should they change their job, or should they make some changes in their lifestyles, or decrease their weight, and do some physical therapy, or go for medications, or maybe in severe cases we may offer some injection procedures, steroidal injections or non-steroidal. There are certain drugs that we use which are derived from the chicken comb. It's like some connective tissue material that we get from that, and it's injected into the joints. Wow. That also helps. So for arthritis, we do all these things, and we manage the pain. There are certain patients we have who are in their early 40s or mid 40s who have end-stage osteoarthritis of the knees.
Wow.
So they are bone on bone. So they have to have knee replacement. There is no other option.
Wow.
But they are too young for a knee replacement. Mm-hmm. So the surgeons are not interested in doing knee replacements at such an young age, which is not advisable. So we manage their pain till maybe for the next 10 years,
right,
till they're okay to have a knee replacement. So this is what we do.
Okay. All right. We've got more calls coming in, and we'd love to hear from you as well. Call us at 737+ with your questions for the doctor. We'll be back after this quick break.